Hi, my name's Carly. I'm a nurse in the PICU. The use of physical and chemical restraints in mental health care has long been an issue. Research by Cusack in 2018 shows that restraints can lead to physical injuries, psychological trauma, and in extreme cases, death. It also diminishes the therapeutic alliance between patients and caregivers, which hinders long-term recovery. Today, I am going to present a strategy that will change our approach to managing these patients, with an implementation of a specialized de-escalation team and more de-escalation training for bedside staff to allow for early detection of de-escalation needs. This team will be available 24/7 to respond to potential crisis situations and will consist of a nurse practitioner or doctor, a mental health social worker, a peer support specialist who is an individual with lived experience of mental illness, and a security officer trained in mental health crisis intervention. This team, as well as all bedside facing staff, will be trained in advanced de-escalation techniques, which includes verbal loop method. This involves a cycle of listening, validating, and responding to the patient. Studies have shown that specialized response teams can significantly reduce the use of restraints. For instance, a study by Godfrey in 2014 found that implementing a behavioral emergency response team led to a 42% reduction in restraint use over a 2-year time span. It's also been found that the inclusion of peer support specialists has been shown to be very effective. In fact, a study by Chinman in 2015 demonstrated that peer support interventions led to increased engagement in care and improved relationships for providers. The implementation process will span across a 12-month period. The first 2 months will include team selection and initial training. Months 3 and 4 will be dedicated to protocol development and staff education. Months 5 and 6 will be the rollout of the pilot program in a single unit. This will allow for initial data and feedback. And months 7 through 12 is when full implementation on all units will take place, as well as ongoing training. To notify the team, bedside staff will identify a potentially escalating situation, activate the team via a dedicated emergency pager system similar to calling a code, and provides the patient's location and a brief situation description. The de-escalation will be a 6-step program that will include rapid assessment, engagement by providers, environment modification, therapeutic communication, suggesting coping strategies for the patient, and then developing a short-term safety plan with the patient as well. After each de-escalation, the team will debrief to see our strengths and weaknesses, similar to what you would do in a code as well. This protocol ensures that restraints are used only in the most critical situations, prioritizing patient dignity and safety while maintaining a therapeutic environment. Restraint should only be used as a last resort when all de-escalation techniques have been exhausted, the patient poses an immediate severe threat to themselves or others, or is actively attempting to self-harm. We will evaluate this for effectiveness through a multifaceted approach. We will take into account quantitative measures. This will take into account frequency and duration of restraint use, number of crisis calls and team interventions, as well as patient length of stay. We'll measure qualitative assessments like staff surveys on perceived safety and efficiency, patient satisfaction surveys, as well as team debriefing reports. We will take into account clinical outcomes, including rates of patient engagement in the treatment and readmission rates, and economic analysis. This will take into account cost comparison between traditional methods and the new approach with our team. By implementing this specialized de-escalation team, we have the opportunity to significantly improve patient care, reduce traumatic experiences, and create a safer environment for both patients and staff. This approach aligns with our commitment to trauma-informed, recovery-oriented care. Thank you for your attention, and I am eager to hear your thoughts, and I am here to answer any questions you have.